I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. Today I'm joined by Dr. Henrik Zetterberg. Dr. Zetterberg is a professor of neurochemistry at the University of Gothenburg and University of College London, as well as a visiting professor and co-leader of the Biomarker Core with the Wisconsin Alzheimer's Disease Research Center. He also serves as the head of the University of Gothenburg's Department of Psychiatry and Neurochemistry and a clinical chemist at the Sahlgrenska University Hospital. His research focuses on fluid biomarkers and the development of new diagnostic tests for Alzheimer's disease and other neurodegenerative disorders. Henrik, welcome, and thank you for joining me today.
Thank you for having me.
We are doing this podcast in person, which is not something I do regularly, so it's very nice to see you and be able to discuss what I hope is both a research and clinical topic, and we'll get into it. My first question for you is, your work has really been pivotal in the development of fluid biomarkers for neurodegenerative diseases. But can you describe for our listeners what biomarkers actually are and share with them the significance of biomarkers like amyloid and tau in the early diagnosis of Alzheimer's?
Yes, so biomarkers are basically measures of something that happens in a biological context. So it's a relatively vague term. But the way we think about biomarkers in the setting of neurodegenerative diseases is that they are markers of something which is happening in the brain. Objective markers, they could be collected through imaging of the brain, but they could also be collected through biofluids, cerebrospinal fluid, and now also blood. And we want a biomarker to have a relatively direct relationship with the tissue process, what's happening in the brain on a molecular level. That is sort of the more focused way we think about biomarkers in this research team here, and I think also globally if we look at dementia researchers.
And I feel like that's the big jump that's hard for, I think, people in the community to understand. What we are testing in the blood is actually reflecting what is happening in the brain.
Yeah.
Because we think of the brain as, protected by the blood-brain barrier, it's separate, but in truth, what you do is you are able to detect and then validate to make sure that what we're seeing in blood is truly happening in the brain.
Yeah, and I mean, this is a surprise to me too. That it's been a very pleasant surprise. So when I started in this field like 23 years ago, then I joined a research team in Gothenburg specialized in cerebrospinal fluid analysis. And this fluid is then the fluid that surrounds the brain and also bathes the neurons and other cell types in the brain. And you can collect it through a lumbar puncture, which is then putting a relatively long needle in the lower back. CSF, cerebrospinal fluid, is on the brain side of this protective blood-brain barrier. So this blood-brain barrier is thought to protect the brain from viruses and from bacteria and perhaps also from some toxins. So if you eat something bad, it will not immediately affect the brain. But that's also, it's a little bit of an old-fashioned way of describing it, because the barrier is not like a solid barrier. It's a dynamic and very biological tissue almost. Protecting the brain for sure, but also letting things in and out from the brain. But when I started in this cerebrospinal fluid laboratory in Gothenburg, we were quite proud of the assays we had developed, where we could measure proteins in the lumbar cerebrospinal fluid that were part of the pathologies that form and build up and progress in Alzheimer's disease. And we could link the lumbar CSF concentrations of proteins like amyloid and tau, core proteins in the Alzheimer pathogenic cascade, to the brain tissue changes. And I thought that we would have to stick to CSF measurements. So we were sort of traveling the world and described our CSF assays and tried to get the rest of the world to implement CSF sampling. And when people talked about blood, I was like, that will not work. But then what happened was that around 10, it's almost 15 years ago, then the assays we were using use antibodies to capture the analyte of interest and then detector antibodies labeled with something you can measure, light or an enzyme that makes color or something that can be measured. Those assays were transformed in a way which gave us 1,000-fold increase in analytical sensitivity. And it was an engineering thing. And the engineers, it was not us, it was people in Cambridge, Massachusetts, who made something, perhaps this will sound silly, but they put the antibodies on beads and could thereby compartmentalize the detection reaction in small, tiny wells that could be imaged. So what happens if there is sunlight present is then you would get light emission. It's like a Chinese chessboard with small holes. And if one hole starts to emit light, this is done in a microscope, I should say that, but then imaged, and most wells do not emit light, you could start to count molecules. And this molecule counting through the compartmentalization of the detection reaction, this is what solved the whole issue. So then we could take the same assays we had used for CSF measurements and start to measure in blood. And then we saw the same things. It's just that the concentration is 100 to 1,000-fold lower. So that was actually what, in our case, made the blood biomarker work in Alzheimer's disease and related disorders possible.
So it was an engineering feat that was incredible to get us to blood. But then I guess I would also say it's really the donation of people's brains, because you have to validate these incredible tests to people who have given their brain for the ultimate diagnosis.
This is completely true. So this wouldn't have happened without people taking part in research. And the brain donation programs have been extremely valuable for this type of research. It has been valuable for diagnostics, but also for development of therapeutics. So for example, this antibody lecanemab that is now available in the US for clinical use, this is actually an antibody that a family with a mutation causing familial Alzheimer's disease helped develop. So this is a Swedish family, and they turned out to have autosomal dominant Alzheimer's disease, and they enrolled in research. He found a mutation. He found that the mutation was in the APP gene, the amyloid precursor protein gene, making a form of amyloid that didn't form big clumps, the amyloid plaques, but rather small clumps that could travel around a bit in the brain tissue, injuring neurons and synapses, giving a very aggressive form of an autosomal dominant Alzheimer's disease. These family members donated brains, donated themselves to research, and helped figuring out that these small forms of amyloid are also present in sporadic Alzheimer's disease, the general Alzheimer's disease that many of us are at risk of. And on the basis of these findings, Lars Landfelt and his team created an antibody that detected these small forms of amyloid. He called it BAN2401. They formed a company called Biomarkers, and then eventually, after having done phase 2 trials, they could show that this antibody modified Alzheimer's disease in a relatively safe way. I mean, it has issues also, but and then Eisai and Biogen got in and made big phase 3 trials, which are the basis for approvals that have now happened in the US and in many other countries elsewhere. Not yet in Europe, which is very irritating for me. But anyhow, and then so people taking part in research like this have then helped developing treatments, and also these diagnostic tests that also can be used to monitor the treatments. I think this is why it's so important to have these alliances between researchers, clinicians, study participants, and pharma industry.
Well, how do biomarkers like amyloid and plasma p-tau that's measured in the brain, the body, the blood, how does that correlate with progression clinically for preclinical stages of Alzheimer's, where there's some subtle changes, to things that like mild cognitive impairment and dementia?
These biomarkers have taught us that Alzheimer's disease start much earlier than we thought before. So it is, we now know that these amyloid plaques, they start to form perhaps 20 years before you have dementia. This is both a little bit scary, and but it could also be a blessing, because we can detect these preclinical brain changes with the biomarkers, because the biomarkers are agnostic to cognitive function. So we can, with the biomarkers, see if there is a biochemical change in the brain, and then with the history of the study participant and cognitive testing, we can see if the neural networks are starting to get disturbed or not. So these are complementary measures. So the biomarkers will indicate if Alzheimer's pathological changes are happening. The amyloid biomarkers in the biofluids, they are, I shouldn't say bimodal, but they are typically normal in all people below the age of 50. At least that's the results from the Wisconsin Registry of Alzheimer's Prevention Studies. There are almost no people who are positive for the amyloid, the biofluid-based biomarkers, who are younger than 50. But from 50, positivity starts to appear. The delta, the change, the magnitude of the change is not that important for the amyloid markers. So then you know, okay, the process has started. But then we have another class of biomarkers which then will tell you how the neurons react to the pathology. So when the plaques start to form, neurons that are close to the plaques will start to phosphorylate and secrete tau. And then that is reflected in the brain interstitial fluid, which you can't sample. It's reflected in CSF, which you can sample, and it's reflected in the plasma. And the results indicate, but it's not a done deal yet, and we need to do more research, but the higher the concentrations are in plasma, the more intense the neural response is. And that correlates group level wise to when symptoms are likely to appear. And perhaps to some extent, but one should never say it for an individual person, but group level data indicate that the higher the levels are, the more rapid disease progression there is. And especially if this is accompanied by an increase in yet another protein, which is called neurofilament light, which is a general neurodegeneration biomarker. So if you have both a phospho-tau increase and an NfL increase, that correlates with a more intense disease process. It could also indicate that you are further along in the Alzheimer process. But somewhere here, one would like to intervene with a drug that stops the toxicity of the amyloid. And now we are in this fortunate situation that we can start to learn how effective these anti-amyloid antibodies are to detoxify the plaques, the clumps of amyloid in the brain, and help microglia basically eating up the plaques and thereby removing the toxic effect on the neurons.
You know, one of the key things that I take away from what you just said, though, is that in research, we look at group level data. You know, we are thankful for all the participants. The more participants, the better. That provides better numbers. But we can't really take that group level data to the individual coming into a clinic saying, well, what does this actually mean for me? What do I do with this information? And so with that in mind, you know, it's incredible what the biomarkers have done. But what challenges do you see in implementing these tools in a routine clinical practice when we're trying to diagnose and then treat Alzheimer's disease?
Now, this is extremely important. So I work also as a clinical chemist in Sweden, and there we have implemented, for example, neurofilament light in clinical practice in blood, and we also now implement phospho-tau 217, which is the most promising marker. We have decided not to implement the A-beta 42/40 ratio. This is a bit technical, but this is the amyloid test in blood. It works beautifully in CSF. And we have done clinical CSF measurements in Sweden for 20 years, actually. So there we have had this opportunity to start to discuss individual patients' biomarker profiles in relation to their symptoms and what is bothering them. And then my advice is super strong here. So but one should never interpret these biomarkers in isolation. So one should put them in the complete clinical context. But then if everything fits, one can look at the amyloid and the CSF amyloid and CSF tau tests, and actually discuss this with the patient and say that this pattern really looks like there might be Alzheimer's pathological changes in the brain, and I think this fits what you have experienced. And we feel quite certain now that this is Alzheimer's disease and not a depression, not a brain infection, you don't have to worry about those things. Now we focus on that this is likely Alzheimer's disease and try to help you as good as we can with this. The blood biomarkers work similarly, especially phospho-tau217. But one phospho-tau217 measurement, one concentration in a person who is asymptomatic, for example, that is never what we would recommend to do. So instead we would like to use the blood tests to help clinicians and the patients to come to a diagnosis quicker when they are in the early symptomatic stage. So we are at the moment we're not proposing that the biomarker should be used clinically to screen for Alzheimer's pathology, because there we know way too little about what the individual biomarker level means for a certain person. But if there is a history of cognitive or other symptoms that would make you think that this could be Alzheimer's disease, you perhaps know there is a family history also, and the thyroid hormones are good, there is no anemia, there is no hypercalcemia, there is no depression, then it looks like the individual phospho-tau217 measurement together with the clinical picture actually can help you to identify people who then should be evaluated further, for example, for start on an anti-amyloid treatment. So it is so I try to encourage people to think about these blood tests. Sometimes we call them blood tests for Alzheimer's disease, but these blood tests would then be additional clinical chemistry tools to help reaching a correct diagnosis. The opposite is then that you have a picture which makes you worry about Alzheimer's. Phospho-tau217 is completely normal. Then you perhaps also do neurofilament light, and that is normal. And then it turns out that this was a bit of an atypical depression, and you treat the depression and everything becomes fine in the end. So it's like, an additional tool to get to the right diagnosis. So you see how interesting and complex it is. But I look at this as something positive.
Well, one of the things I hear from you, because I agree with you completely, is the timing matters, the context matters of the person that we're trying to help.
Yeah.
And so you're not, and I know a lot in the field, are not suggesting that this test just be a mass screening test or available just for people who are interested. It is really meant for those who are experiencing cognitive change, likely have a diagnosis of mild cognitive impairment or dementia, and the clinician is suspecting either this is Alzheimer's disease or is not Alzheimer's disease. And this biological test will be helpful in cementing that diagnosis.
Exactly.
And then there is a context where you would say, let's say you don't have cognitive impairment, but there might be this therapy that would be meaningful for you, whether it's clinical trials and research or eventually down the road, a preventative therapy. Well, then maybe before you have actual impairments, you would have this test and it would guide therapy. But we're not there yet.
But I agree with you completely. But I hope we will get there. So I've been thinking about these amyloid clumps in different ways over the years. So for a while I was thinking that that you could have amyloid pathology for many years and still not have any symptoms. Then one of my bigger first projects were meant to try to find out if there was basically a chemical difference between early plaques and late plaques in terms of neurotoxicity. But we have not been able to see this. So instead, I think it is like this. But this is, of course, speculation and a hypothesis that need to be tested. That as soon as the amyloid plaques form, you get an immediate neuronal reaction by those neurons that are close to the plaques. And that could be a little bit of a pruning-like thing, that amyloid, there are some data indicating that the biological function of amyloid, because all of us make it and it's conserved across the animal kingdom, it's really a conserved, that this peculiar small protein together with complement could label synapses that should be removed. And so the complement and amyloid could signal to microglia that this is a synapse that we don't need anymore. Let's remove it. that's a normal brain function, which is really important. We need to be able to forget things, and we need to also remove synapses that are not used, so that other synapses that are needed can take their place. When you get Alzheimer's, you have these amyloid plaques that never disappear from the brain tissue, giving a constant pruning signal, and then synapses are removed. Then, of course, that will induce neuronal network disturbances. But then it's so fascinating, because then the brain can compensate. It's really, that's a core feature of the brain. It's amazing. So then the brain will try to make sense of the disturbance and find other ways of doing what it needs to do. And I think that explains why we can live with these plaques and still function relatively well. I still think that you might experience some subtle symptoms. Perhaps you get a little bit more tired or irritated if there are lots of things happening, if you have a big family dinner and it's like chaos, and then you can't take that well if there are these processes ongoing. But this is speculation. But I have abandoned the inert amyloid pathology hypothesis. I think it's not inert. I think there are things going on. So then it would make sense to me that starting on an amyloid treatment in clinical overt stages, before clinical overt stages, would be good. And trials are ongoing with this in this regard. So we have to look at them, and if they turn out to be really good, then we have to start to discuss screening. And I think the blood tests can help there. But this we have to work together, patients, clinicians, and the pharma companies, to figure this out. But it's not completely unrealistic or science fiction that there could be a screening program in the future. But we're not there yet. We have to learn how to use the antibodies in the clinical setting better. And then, of course, there are so many interesting things happening with new treatments that perhaps are a little bit safer. I mean, there are side effects with these anti-amyloid antibodies, with headache and fluid dynamic changes, and also these disturbing few cases of bleeds. But still, one has to be careful there. So it's, and we also need to figure out why some get these types of complications. Could we identify who is more likely to get this side effect, which is often called an ARIA, amyloid-related imaging abnormalities? It's such a strange word. It indicates that we don't know exactly what is happening. But those side effects, the dangerous forms of ARIA, we would like to be able to identify. And there I think we need to work together on developing a blood test that could predict or identify people who are at increased risk of ARIA. There are data already that we can potentially use a genotype to do this. The major susceptibility gene for Alzheimer's disease, the ApoE epsilon 4 allele, that almost 20%, at least in Scandinavia, it's 20%. It's a huge number. If you have Alzheimer's running in your family, then there is a little bit of a risk that it's an ApoE4 related process. But then that ApoE4 genotype is associated with sporadic Alzheimer's disease, as many of you who listen know. It's also associated with a side effect. So it's very disturbing because I also think that ApoE4 homozygote people are the ones who need the treatment the most. And now there are some worrying results that perhaps they then shouldn't get the treatment according to some people. But I hope it is like this, that the ApoE4 association with a side effect is simply that you have more of the pathology that the antibody is supposed to remove, and that's why you get more side effects.
But you've mentioned a lot about blood, blood-based biomarkers or biomarkers to help us figure out ARIA or potential therapeutic benefit. But of course, you started in spinal fluid, cerebral spinal fluid. So is there something, though, that cerebral spinal fluid can offer us that blood simply can't offer us? Because in essence, what I'm asking you is, do we still need to be doing lumbar punctures in the research world? Yeah. What is it that CSF can offer us that we're not getting anymore from blood?
I love CSF. This is that perhaps I shouldn't say like that, but CSF can offer something unique. So if you're part of a study where CSF sampling is in the protocol, I would highly recommend it to you, because it's such a gift. And especially neuroinflammatory processes, which are really in the limelight now also of that these processes are part of the Alzheimer's pathophysiological process and also across neurodegenerative dementias. It's very clear that microglia, astrocytes, they play a big role in the neuronal impairment that you see in Alzheimer's disease and in other neurodegenerative dementias. When we try to measure these proteins in blood, only a few work. In blood, there are so many inflammatory cell types that sort of contaminate the blood with, to me, uninteresting information that makes the measurements not work that well to detect the brain changes. So that is one particular situation where cerebrospinal fluid is good. If you're a patient and you are experiencing cognitive problems and you might have had some neurological symptoms, then your clinician might want to do a CSF to examine for multiple sclerosis or for Lyme disease. That's very easy to diagnose if you do a CSF sampling. So I see a strong role of continued CSF sampling, both in clinical practice and research settings. But in clinical practice, I think actually the blood biomarkers could replace both PET and CSF in clear-cut cases where you sort of feel confident with the information you have gathered. So, and I like that. I think that is that's also how other specialists in other organ systems often work. I mean, a cardiologist has so many tools to examine the heart, and then eventually he or she might decide on doing a biopsy to find out if this is a difficult diagnosis to make. So going from easy tests where you could make most of the diagnosis in an accurate way and feel very confident that you are treating your patient in the best way possible, to more advanced cases going via. So, but then we have come far with CSF and the advanced imaging that is possible now.
Well, as a clinical chemist, though, what do you think about that could impact the meaning or interpretation of a plasma or a blood biomarker for Alzheimer's? I mean, does kidney function, does the weight, are there things that you consider both in research and clinic that we should be aware of? It's not perfect yet, or at least we have to account for certain factors.
Yeah, this is also super important. And one has to remember it's still early days for the blood tests, and we are continuously learning. So we have learned that if you have active cardiovascular disease, then phospho-tau levels are increased a little bit. They're increased by 5-10% in epidemiological studies with large numbers of study participants. But still, if you have kidney disease, you also have a similar effect, and we don't understand why. But there is a certain effect of kidney dysfunction. If you look at a lot of plasma phospho-tau 217 measurements in, for example, the RAP study or something else, where the numbers are high, then you see this association, which is statistically significant. But then we are in the fortunate position that the amyloid effect on the plasma phospho-tau marker is 2, 3, 4, even 5-fold. So this 10%, it doesn't destroy the marker. But it's important still to know about it, because if you are examining a patient with kidney dysfunction, which is known and diagnosed, and this patient is at a limit, then, and perhaps this could push the person above the limit. But then it's really important to know that this is not enough to make a diagnosis or support a diagnosis. There are ways many research groups are now trying to refine the measurements to reduce the impact of these confounders. I mean, we look at them as confounders. So one passive way of dealing with it is to simply tell about this and make sure that people who are using the biomarkers know about it. And since I work in general clinical chemistry, I also know that the clinically used cardiac biomarkers, troponins, for example, they are impacted by kidney disease, blood volume. It's very similar, and still they are useful because the clinicians know how to use it. And the clinicians in a setting of cardiology, you often look at dynamics also. But that we can't do in neurodegenerative diseases, at least not short term, like you can do in cardiology, where there is a dynamic and ongoing disease process, which is reflected by fluctuations in the biomarker, because the disease process is so slow. But I think in the future that it could be, depending on what happens with preclinical treatment of disease, that one scenario could be that you actually, especially if you are in a family where you're worried about that you have, well, if you have a family history, that perhaps you would go and check your phospho-tau levels, and then perhaps your individual change might tell more about onset of a disease process than your absolute concentration. But here again, we don't know this. We have to examine it together.
Well, to end our conversation today, I'd like to cover other non-Alzheimer's changes in the brain.
Good.
Because not everything is Alzheimer's, and certainly these other conditions that I know you study impact how people experience symptoms and declines and impairments. So where's the field on Parkinson's disease, Lewy body disease, frontotemporal disease? What other biomarkers are people researching in hopes of having a full brain panel?
So I have almost started to not focus that much on the Alzheimer biomarkers, because I think the urgent need now is to develop better tools to detect the other pathologies. They have strange names, but it's TDP-43 pathology. This is an inclusion that forms inside neurons in relatively many of us. It's a very common feature of Alzheimer's disease, like one additional finding. If you stain for it, you detect it in surprisingly many people. And the other protein is called alpha-synuclein, which is strongly linked to Parkinson's disease. But it's also seen in Lewy body dementia, which that's almost like, that is an oversimplification, but it's almost like a mix of Parkinson and Alzheimer's. And then you will experience symptoms that are really different and important clinically, and it's really important that you get help with those symptoms too. It's both strange hallucinations, and your blood pressure regulation might become really problematic. Many things that need to be dealt with clinically. And then we think that these proteins are actually actively contributing to the neural dysfunction that gives these types of symptoms. At the moment, we can detect alpha-synuclein pathology in a lumbar CSF sample. It's not clinically implemented yet, and the test is quite difficult, I must say. But it works, but you have to have very rigorous control of how you perform the test. Basically, it's a test meant to detect small seeds of misfolded alpha-synuclein, which might leak out into the CSF for people with alpha-synuclein pathology. And then these small seeds can misfold exogenous alpha-synuclein that you make in the lab and spike into the CSF sample. And then you can monitor misfolded aggregation with a special fluorescence technique. So that is working. But we do not have a blood test. But I think there is potential for a blood test. And the same is true for TDP-43. So here in Wisconsin, we are right now designing a TDP-43 biomarker discovery project, which will be a full force project with a lot of different expertise coming in, both from imaging, from our biofluid biomarker laboratory, from all our clinical colleagues, from geneticists, and from people who also help phenotyping people with these types of disorders. And it's super important for many reasons. It's important to help diagnose diseases that are not Alzheimer's. It's also really important, I think, but again, it's a hypothesis, to see if Alzheimer patients who also have these other changes, are they more or less in need of the anti-amyloid treatments? Could this help explain if a patient might do well on the treatment or not experience benefit and just risk side effects? This could also be something which we could make clinically useful. So these types, alpha-synuclein and TDP-43, are in focus, and this is also happening in other parts of the world. Many researchers are looking into this now. And the University of Wisconsin has a strategic collaboration with the German DZNE network, where a wonderful researcher, her name is Anja Schneider, she has developed a test where she uses blood, but she extracts small vesicles from the blood and then she lyses these vesicles and measure TDP-43 and alpha-synuclein with the same assays that we have up and running here. And then she sees an association with the TDP-43 associated forms of frontotemporal dementia, which is an important dementia that we need to develop better tools to detect for, and also better treatments. And in the same vesicles, she can lyse them and also measure alpha-synuclein, and she has a signal there too. So she's actually now transferring this test to us. There are other approaches to developing better biomarkers that we will explore that relates to what these pathologists do to splicing of gene transcripts that might give changes in the biofluids, where there are promising pilot data. But a lot of interesting things are happening. There is a final thing, and now I've talked a lot here, but there is also a need, but I mentioned it slightly, but we need better biomarkers to detect cerebrovascular disease. The imaging biomarkers are really good, but it would be nice with a blood test. And also, isn't it irritating that we don't have a blood test for the cerebrovascular? I mean, it's very close. The cerebrovasculature is adjacent to the bloodstream, so we should be able to do it. So lots of possible ways forward towards a more inclusive biomarker panel that would help with the full scale, I should never say the full scale, but most of the diseases that cause brain dysfunction in a way that could lead you to think about Alzheimer's and the other forms of dementias.
So it sounds like the future, and even the near future, is going to be very exciting. Lots of developments and a very broad approach to all the different brain diseases that are out there.
I think that's the perfect conclusion.
Yeah.
It's a very exciting time. And it's become super exciting thanks to the interaction between engineers, chemists, inventors basically, and clinicians, and people who take part in studies, and families who donate time and resources to help the research, and imaging people and people who do genetics and clinical phenotyping of people.
Well, with that, I'd like to thank you, Dr. Henrik Zetterberg, here on Dementia Matters.
Thank you very much.
Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, or wherever you listen, or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. If you enjoy our show and want to support our work, consider making a gift to the Dementia Matters Fund through the UW Initiative to End Alzheimer's. All donations go toward outreach and production. Donate at the link in the description. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research. This episode of Dementia Matters was produced by Amy Lambright Murphy and Kaylin Rauerdink and edited by Alexia Spevacek. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. And follow us on Facebook and Twitter. If you have any questions or comments, email us at dementiamatters@madison.wisc.edu. Thanks for listening.